and welcome to tonight's edition of Rural Doctors. I'm Jerry Gannon. Thanks for your company. Our final program for 2010 looks at mental health. Olga Ward and psychiatrists Jim Goodburn and Eileen Tay look at 3 different mental health case study reenactments and discuss the best management plan for each patient.
Eileen and Jim, welcome to the program.
Thank you.
Before we start looking at case studies, are there any real issues in mental health that you see in rural general practice as being really important?
Mental health concerns are very, very common.
Yeah.
It's the first important idea. The second thing is that they're very often hidden, so people will come in with some other complaint underlying it or associated with it that may be a mental health problem. And the other thing is that it's really important to identify mental health concerns because they often have high risk attached to them.
Certainly in these current conditions of drought, I know the farmers are all pretty depressed and so are their families. Eileen, is that something you're seeing a lot of at the moment?
Well, a lot of so-called stress-related conditions or what are understandable stress reactions can often translate into a more serious problem and it's important that we're aware of that. For instance, how depression can supervene on top of chronic stress. So those are kind of important issues to be aware of as well, instead of just saying, oh, this is an understandable reaction, and the point at which this understandable reaction has started to change.
Being aware of that, we might have a look at the first case study, which is indeed a farmer.
Good day. I'm Jim.
Hey, Ron.
Nice to meet you, Ron. What's happening, mate?
I think you've seen my wife Mary. She pretty much told me I had to come in and see
So
her.
it was her idea for you to come in?
Yeah, I think she's had a gutful.
All right. Okay. So is she here today with you?
Yeah, she's out in the waiting room.
Okay. Can you tell me what's happened? Obviously, you worried enough to come along and see me.
Well, it's a bit of everything, really.
Something must be happening for you right now that's worrying you. I'm wondering what you're worried about.
The crap seasons for 4 seasons.
Yep.
And it's a lot of pressure. I don't feel like doing much. I just feel like crap.
Sounds like your mood is down. Would that be right?
Yeah. Mary's a saint. She really is. But she's had enough. And
it sounds like you've stopped enjoying a lot of the things that you would normally enjoy as well. Is that?
Yeah.
It sounds like.
Yeah.
You look depressed to me. Is that how you're feeling?
Well, I don't know. People talk about being. I don't know what depressed means really, but
Sure.
I can tell you, it's just. I was raised on a farm. My grandfather started the farm, and it's a mug's game, Look, I've got to be honest. I'm 55. What future do I have? The kids are off our hands. Mary and I rattle around in the farmhouse. We don't talk to each other for, half a day on end. But what have we got?
Okay.
I can tell you what we've got debt. That's what we've got. There is no future that you can see.
How long have you felt like that?
I don't know, 18 months.
18 months, okay. Did it start gradually? Did it suddenly come on 18 months ago?
I think when you turn 50, you just start to... Is this all there is, I mean, I've got 3 brothers. All we do is argue about the money we don't have.
Right.
Because, when the old man goes, we own the lot. Well, it's a quarter of bugger all at the moment. It's a quarter of the debt, basically. But we still argue about it.
Let's look at how your mood is and how severe it is at the moment. When you said you're feeling like, things are pretty bad, are you feeling hopeless, like you've lost, obviously you said you lost control of stuff. Are you feeling hopeless about life?
Yeah.
What kind of a future do you see, actually? Can you see a way out of this?
I won't say I haven't thought about what you're talking about.
What do you think I'm talking about? I'm asking you if you've thought of actually ending it all or hurting yourself in any way. Has that thought crossed your mind?
I've thought about it, but I don't have a. It's not like I have a plan or something, you know. But I can't see a way out. I just can't see a way out. And I look at Mary and I think, you know, she's had 25 years of this shit, and if I look back, look, you have your good years and your bad years, but there's never been what I would want for her, you know?
So you're worried about that. We might need to come back to some of that family stuff.
Yeah.
I guess what I'm really wanting to nail at the moment is what's happening for you. You're not sleeping well?
I can't. I wake. I get to sleep. I'm fine. I'm buggered after a day's work, but then I wake up in the middle of the night and it's just full on, you know. Money, how are we going to do this? How are we going to do that?
So you're worrying at night?
I just worry at night. I get up in the morning and it's like I haven't slept.
What about your appetite? Has that changed?
Like a beer, but no, I'm just, yeah, look, I just don't feel like it, you know.
And your weight, how's that been going?
I lost a bit of weight, but it's more that nothing feels right.
Okay, now you mentioned beer just then, I'm going to pick up on that.
Yeah.
How much do you drink?
Oh, I don't know. Don't really count.
So you drink every day?
Oh yeah, but I mean, we've always drunk every day.
Your last drink, or your last session, how many did you have?
I don't know, 8 or 10 maybe.
What, beers or
yeah.
whatever? Okay. So what do you think leads you to the drink that much?
Oh, it just takes the edge off the day, I suppose.
Reduces your worries and things, takes some of the edge off it?
Yeah.
Okay.
I think so.
Do you use anything else to stop worrying?
I was seeing another GP and he gave me I think it's called Ativan, you know, because I get very anxious, and he and the wife thought that it might help, so I've been taking that.
You know, I can see that you're under a huge amount of stress, and people often in that situation, they get anything, they try, they seek around, they go to other GPs, they even get it off the street sometimes, or from their mates or from their wife. I'm just wondering what else you might have been able to get hold of to help you in this situation.
Does my wife have to know?
Sorry?
Does my wife have to know about them?
Not necessarily, although at some stage it might be worth talking it out. But the immediate thing is to let me know what's going on. For your own good, really.
I've been to see a couple of GPs about getting the tablets.
Okay. And what were you going to do with those tablets?
I just like to have them around, to be honest. Just in case, I suppose.
In case of what? Right.
What you were, in case, what you were talking about before, I think.
So the suicidal thoughts come back, is that what you're saying?
Yeah.
Okay. And so sometimes you think that things are so bad that you need to end it all? Perhaps with taking too many tablets? Is that what you're thinking?
Yes.
Okay. I'm really glad you're able to tell me that. So it raises a pretty serious question, doesn't it, about your safety at the moment?
Yeah.
And it sounds like things are really out of control for you. So we need to deal with that, because I see that you can get through this. And I think the best way of doing that would actually be to involve your wife. because, you know, we need to talk about how we're going to help you.
Okay.
Yeah.
That consultation brings out quite a lot of points. One of the things I noticed you doing when you were talking to the patient, Ron, was validating a lot of what he said and kind of saying back to him.
Reflecting back is actually a way of getting them on side, so they can feel safe and contained. That's a really important part of working with somebody who's got depression.
Eileen was making a point about how normal stresses and the normal response to stress can actually then flow over into a depression. What sort of features do you look for, and how do you bring that out in the consultation?
Well, I think that demonstrated how Jim was already picking up on aspects of his, if you like, mental state. That is, commenting on how he wasn't enjoying things any longer, and then focusing on how his mood was down and how, you know, he was also irritable, which is fairly common too. So I think those are important kind of aspects of the consultation, that you're kind of searching for clues, if you like, to say that this is more than just, you know, a stress reaction, if you like. That presentation, that consultation really, and how Ron presented, you know, the first thing you would notice is that he looks down, he looks depressed. He's not trying to make light of his situation. He's not trying to be cavalier about, yeah, you know, the missus brought me in, you know. So I think those are important flags too. He's certainly taking it seriously.
I think we also have to keep in mind that while women tend to be much more comfortable about presenting to their doctor with mental health problems, men don't.
Yes.
But if you look at the statistics, men have a much higher suicide rate, a much higher kind of risk. So when a man presents, however he's brought in, we have to take it seriously. And the other thing which I feel very strongly about is in the country where you know, there is a lot of stress and it's ongoing, it's unrelenting, we have to take those kind of stresses very, very seriously, because you know, it's not uncommon to get a number of suicides happening or suicidal behaviour happening in one small area. So we have to take this seriously.
What sorts of initial management would you see as absolutely essential with this sort of depressed patient?
My main concern about this man was his risk of hurting himself or even killing himself. That's my main concern. If I haven't dealt with that in some way in this consultation, then I haven't done my job. So picking up on the idea that his wife brought him in, I want to actually get her into the consult at that time, because he lives miles out of town. This may be the best opportunity we've got to actually grab him while he's okay about seeing somebody.
Is that going to make him less likely to top himself?
I think so, because we obviously didn't get to a management plan. But with somebody who's, you know, hesitant about coming in, who's a male and he's a man, and therefore kind of less likely to be okay about talking about depression and management of depression, but also being a very high risk. You know, we need to get his support partner, his wife, into the room to then discuss what we're going to do, whether it's to put him in hospital, whether to send him to Perth, whether to, reassure, get everybody reassured that he is contained and safe, and start him on some treatment locally. You know, all of those are options which could be explored, but it's much better to explore those kind of options with the partner there, because you're going to get a collateral history, and it might really seriously influence how you are going to take the next step.
Is there one thing about patients, or several things about patients, that say to you always, this patient is a really high risk of suicide? You know, something that sets off all your alarm bells?
There are general ways in which we can look at a patient. You know, he's male, he's under stress, all those kind of things. That makes him risky. Being a farmer, he's also got access to ways of killing himself. A lot of people have guns and that sort of stuff. So that's also worries me. You know, what's there? That's one way of looking at it. The other way is actually like, what is it about this particular man at this particular time that is worrying? And what worried me was he doesn't seem to have a future. He cannot actually see into the future, and that's a very important marker of a higher risk of suicide.
His hopelessness.
His hopelessness, you know, and I always look for that. And there's a lot of research now pointing to the idea that that's something you have to ask about. And if you don't get a good answer, well, you know, I've got a forward plan, yes, I'm looking forward to these things next year or whatever. If you don't get that, it's blank. That's a worry.
Jim, sometimes, and particularly with big buffy farmers, drug use and more specifically alcohol use are quite a touchy topic, and they often really don't think that they're having much of a problem. How do you kind of approach that and follow it up with this sort of patient?
I think it's a really important idea to, you know, to consider with someone like this, because they use, someone like Ron would use alcohol and benzos and other drugs to dampen down their anxious feelings and to cover up their feelings of depression. So it's kind of like self-medication often. Yeah. He gave that away. He mentioned that he had a beer. So, you know, that was a useful way to kind of go in and ask about alcohol. So we pick up on that. But I mean, even if they don't sort of bring something up about it, we have to ask about it because it's extremely common, and of course it's a major risk factor for suicide as well. Alcohol is often fuels acting on suicidal thoughts.
What I tend to do is just to say, look, as part of my normal kind of assessment process, I ask everybody about this, and so that he's not, you know, feeling too threatened about it and doesn't get defensive about it. And, you know, in times of stress, you know, people tend to drink a bit more, and I wonder whether this has been happening for you. And as a way, again, of kind of trying to normalise it a little bit to introduce the topic.
Let's go back into that consultation and just see how you started to pick up some of those threads and start to get some management happening.
We've just had some discussion about where we're going from here. And if I can just summarise that, I know you're probably finding it hard to take things in. All right, so you're going to take the antidepressant and start that at the lowest dose. Yeah,
give it a try.
And get back to me in a couple of days about how you're going with that. We've run a whole lot of tests off. We've ordered those, so you can get those done in the next few days. Yeah. Find out how you are in your physical health. We've had a word with your wife, yeah, and she's on side, but we need to have another discussion very soon with you and your wife in here about where things are going. Yeah. And to keep tabs on how you're going, especially with regard to your safety. Yeah? Yeah. So with that in mind, we've also got a lot of emergency contacts. You can either phone here or there's the mental health unit. But I'll write those down for you, all right? So you've got those available if things are looking a bit worse for you. Is that all right?
Thanks.
Okay, mate.
Appreciate it.
Well, I'm really glad you could make it in here today to see me. So we'll see you soon.
Thanks.
All right? Okay.
Thanks, Jim.
Take care, mate.
Appreciate it.
Okay, Jim, in a country situation, obviously when you're starting to get the support person in and start to formulate some management, your options are a bit limited depending on your staff. What were you trying to set up, and where are you going from here with this patient?
I think so much depends on local resources, really. You know, whether you've got staff who are confident about managing mental health issues, whether you've got a hospital facility that might be able to look after him and contain him and just make sure that he's attended to and his risks are minimised. If
he's not actively suicidal, is he a suitable person to admit to a country hospital?
I think that's something you negotiate with him and his wife. You know, I think that's something you can't answer generically. It has to be sorted out at the time. Yeah.
And I think it might be stigmatising too to admit him too soon, in a way, to a country hospital, and perhaps, you know, establishing communication and contact, even by telephone, initially to see how they go, and then reviewing it, but making sure that there is a process where his mental state, if you like, is reviewed frequently. and especially after the initial agreement of a plan. For example, they might go home, agree to detox off the alcohol, have a plan for that with his wife supervising, starting the antidepressants, reassuring him a lot that you know, his condition is treatable and that there's a lot that can be done for it, but we need to take it in steps and we need to be in frequent contact.
By frequent, do you mean, would you be seeing this guy weekly or more frequently or less?
Ideally weekly, I think, as a minimum, but telephone contact would be also very useful.
Yeah, I think a really good nurse who's okay with mental health concerns, who could do mental state checks every day even, depending on how far out they are out of town. Yeah. I just want to make a comment about firearms. I would, if this guy's got firearms, I would make sure that they're safely locked away and someone else has the key, or that he hand them in. The other thing is that he's admitted that he's got a stash of medication, right? And all he needs is a couple of hours of sinking into depression again. Those, you know, to actually act on his suicidal thoughts. Yeah. They need to be in, you know, found and brought in by a nurse and that sort of thing. Help. Yeah, that's right. You know, those things need to be tidied up if he's going to go home, to minimise the risk of acting on things.
Fabulous. Well, let's move on to a completely different type and have a look at the next case.
G'day, I'm Jim. Pleased to meet you.
Yep.
Yeah. So what was your name?
Pete.
Pete. G'day,
Yep.
Pete. How are you, mate?
Yep, fine.
Yeah, that's good. What can I do for you today? What's happened?
Well, you tell me.
I haven't seen you before, have I?
No. I was told to come here.
Okay. Who suggested that?
Some nurse up where I used to work.
Okay. Tell me what's happened.
About what?
You obviously came to see me today about something.
Yep, because I was told to come here.
Okay. Can you tell me what's happened recently that brought you to this point?
Well, I've been told that I can't work anymore.
Is that right?
Yeah.
Who suggested that?
My boss.
So that must be pretty upsetting for you.
Yeah.
Yeah,
it is.
Yeah, it would be. Yeah, okay. Yeah. Tell me what happened to get to that point. That your boss would say that. I mean, that's...
Yeah, well, he reckons that I'm on drugs or something.
Oh, right. Okay.
I don't know.
So, is that true?
No, I had some test and apparently it was positive. I don't know why, but it is, and that's why I'm here.
Okay. So you're really worried about the effect that test has had on you?
Well, I've lost my job because of it.
You lost your
job.
Yeah. What were you doing? What was your job?
Truck driver.
Okay. And who were you working for, mate?
A mining company.
Is it up north?
Yeah, it's in Karratha.
Okay.
Yep.
All right. Okay. All right. So you had a drug test.
Yep.
And it proved positive.
Apparently.
And they said you've lost your job.
Yeah.
Just devastating, mate.
Yeah, it is.
Okay. So I can see why you might be here today. Did you want to get some help from me about that, or?
Well, I want it sorted out actually, because you know, it must be some kind of mistake. This drug thing.
Okay. All right. So you wanted me to sort that out with the
Yeah.
company, or?
Yep.
Okay.
Yep.
Okay. I'm very happy to kind of explore that. I need to ask you a few things around it, if that's all right.
Okay.
You know, like, one of the things I want to know is what test you actually had positive. What did
it was
you
a drug
test positive?
test.
Yeah. Do you know what drug it was that you tested positive for? Any idea at all?
Dope or something, I don't know.
Dope. Okay.
Maybe.
Or cannabis. Have you ever tried that? I know a lot of people who work in the mines and they smoke the odd bit of.
No, I don't do it up in the mines.
Okay. What about when you're off? I mean, you have time off.
Oh, the couple.
Yeah.
But that's, you know.
Yeah,
This is
about,
about,
you get together with your mates.
It's not like I'm being unsafe on the job, you know.
Sure. Okay, no, I understand. I pay that. Yeah, that's fine. But when you're with your mates, you might have a few.
Sometimes.
Yeah, share a few cones, or.
Yeah.
And do you think that might have come up on the test?
Look, I don't smoke weed when I'm there. It's you know.
A lot of people don't know that when they smoke some cannabis or dope or whatever, it hangs around in the system for a long time and it can turn up suddenly on a positive test. You may not have been aware of that.
What?
You may not have been aware that that was possible.
About,
That if you smoke a bit of dope, and is something happening up there for you?
no, it's fine.
Yeah. So you can smoke dope and it can come out positive, even though you think it's out of your system.
Okay.
Yeah. Just wondering if you have any other, if you've tried anything else with your mates. Have they slipped you something, or do they smoke amphetamines and stuff like that as well?
I don't know. A couple might do.
What interests me about this is to try and help you through this, all right, so that you can get back to work.
Yep.
Because that's where I think that
that's what I want to sort out today.
Yeah, cool. All right. A couple of other things. You seem a bit worried about stuff. You seem to be.
Well, I'm worried about my job.
Yeah. Okay. Is anything strange happening for you at the moment?
I don't know what you mean.
Any strange experiences happening? I just wondered whether you were having any feelings that people were getting at you. Or...
Yeah. I've got friends. I've got enemies.
Yeah.
Whatever. But they can deal with their issues.
All right. What are your thoughts about the people at work? Do you think they're having a go specifically at you?
Yeah, they don't like me.
What makes you think that?
I'm not blind. I mean, I can see that they don't like me.
Right.
They bitch about me when I'm up there, and
how do you know that?
I just know.
You kind of just get the feeling. You kind of get the feeling that they do that.
Yeah.
Yeah.
I mean, yeah.
Okay.
And sometimes I'll walk in and then they'll be speaking about something very, very weird. And so clearly what's happened is I've walked in on them talking to me about me.
Talking about you?
Yep.
Right. Okay. How long has that been going on? Sorry.
People not...
That feeling that people are getting at you.
Oh, since I've started.
Right.
They've never liked me.
How long ago was that?
7 or 8 months ago.
Right. Did you ever have those experiences before that in the past?
People talking about me.
Or just feeling that people are getting at you in some way, or trying to have a go at you.
Sometimes.
Have you ever noticed any, like if you smoke a bit, that you get more experiences like that? Like feeling that people are getting at you, or have you noticed any connection between those two things?
I don't think so.
Okay.
I don't think so. I mean, when you're high, everything seems a bit different. But these things happen when I'm not, when I've not been smoking.
Okay. Yep. Sure. All right. Let me ask you a few more things about how you're feeling at the moment.
Yep.
Have you ever, either now or in the past, had any strange voices happening for you that you can't explain? They're coming out of nowhere.
Hang on. Have you been speaking to my boss, or?
I didn't know about this until you came in today. So everything that
right?
you've told me, yeah. And I might say that everything that you're telling me is confidential as well. So it's between you and me. All right. We don't have to take this further, unless we particularly need to. So what about alcohol? I didn't ask you about that before, but do you drink very much?
Yeah.
How much?
Like on the weekends.
Yeah, you give it a nudge there. How much?
What, in a night?
Sure. Yeah.
Half bottle of whiskey, something. Maybe more. I don't know. I don't count.
And that's a fairly common thing for you.
Oh, I can handle it. It's not a problem,
Mm-hmm. One of the things that I feel that is very important to discuss is that cannabis and amphetamines and a lot of drugs, including alcohol, can make some people feel a bit more aggressive than normal. I'm wondering if you would accept the idea that there is something more to discuss about that.
Well,
and it's going to keep putting you at risk of losing your job.
Right.
Now let's come back to that. I mean, that's what's worrying you, isn't it? Losing your job,
Yeah.
Not having employment.
Yeah.
All right. Well, it's likely to keep happening, mate. It's likely to keep happening if you keep doing that stuff.
Well, Jim, he looked like a very difficult patient to
was
connect
tough.
with. Can you talk a little bit about connecting with patients who look like they might be either actively psychotic or perhaps actively on or coming down off some interesting substances?
The first thing to say is it's difficult, and we shouldn't, we should accept that. But to answer your question, I think we have to connect with the person. We have to kind of work with what motivated him to come along. So that's the key theme all the way through that interview is although I disturb him a lot by asking him questions which he doesn't like to answer, I'm trying to connect with his motivation for being there, which is he's lost his job and he wants it back. So everything I do has to come back to that somewhere. That's the way to join with this guy.
Now, he looked pretty belligerent to me and did a lot of kind of leaning forward, and that looked pretty threatening. Particularly, Eileen, you're not a very big person, and I'm not sure that I'd particularly want to have him between me and the door. How do you look after your own safety with a patient like that?
Look, I guess if the sense is that he's not going to respond to, say, something like, the idea of helping him, I might comment on, is there anything else we can do to make this more comfortable for you, because this is a tough situation that you're in. What do you need to just feel a bit more comfortable? Can I leave the door open for you with that? I might try and kind of talk him around that way. But I guess ultimately, if I'm feeling very threatened, then I would actually terminate the interview and suggest he comes back a second time when he's feeling a bit calmer, or he wants to bring a friend or a support person, and we can go from there.
With this particular patient, I was beginning to think maybe I needed someone else in the room, just in case, just in case he became, belligerent or a bit more dangerous. There didn't seem to be any evidence of that, so I didn't act on that idea. But it's an important consideration.
Now, he's not floridly psychotic at the moment, but it's obvious that there's something pretty significant and paranoid going on there. What happens if he doesn't come back?
An excellent question. That's a tough one.
That's not fair.
That's your question.
Ask your colleague to see the patient.
Yeah, what are your thoughts on?
Look, I guess it will depend a lot on where he is and what kind of resources or facilities we've got, but and it would be important to follow it up, as in trying to make some sort of contact with him. He would have contact details on file if he doesn't come back, and even a phone call would be important, I would think, just to see how he's travelling. Normally he would have an accompanying kind of letter from the nurse at the work site, and that would be a reference point as well, to just say, look, this guy didn't come back.
Yeah, I guess there were two concerns about risk with this young man that go through my mind. One is, he is psychotic. There's no doubt about that. And patients can often minimise how they present that. So he might actually be much more psychotic than he actually appears. So that raises the question about, how intensively you might want to follow him up. You might get someone with mental health training, or maybe a couple of people, to go and check on him and see how he is, especially if he lives locally and, you can contain him. The other thing is to let mental health, regional mental health people know, like, emergency teams and people like that, just to flag him, because I think we have a responsibility, confidentiality notwithstanding, we need to let perhaps other agencies know. And the other separate area is he's actually said he's worried about his workplace. People are getting at him there, and I would actually, if he didn't come back, I would definitely contact the workplace nurse or medical people and just ask a little bit more about this guy's history, and to ask whether, and to just explore whether he might be a risk to them.
Just in case he turns up.
Well, just in case he turns up, because
decides to have a go with a shotgun or something.
Well, you never quite know with someone like this. So, it's difficult because you don't want to be over the top, You don't want to make too much out of it, but you also don't want to ignore the risks. So it's often a difficult question.
And in a rural area, you're going to be using your community mental health facility.
That's exactly right. And I think we have to discuss. This is a case we discuss with our colleagues. You know, you have a case discussion about what do we do. You don't just try and contain it by yourself. I think this is something you have to share.
So let's have a look at the end of that consultation and see how you manage to, if not resolve anything, at least get the patient on track for some management.
Would you like to get another test done, an independent test done here?
Yep.
All right.
You can do that here?
Yeah, we can organise that here. All right.
Can I do it now?
We can do it in a minute.
Right.
Yeah, we'll get the practice nurse to organise that for you.
Yep.
All right, and I can sign the forms. That's
Sure.
fine.
Yep.
All right, it'll be totally independent then.
Yep.
There's something else I want to ask you about. You're very, very agitated. You're very worried at the moment, aren't you?
Yeah, well, wouldn't you be? If I told you you didn't have a job.
I would be.
Yeah?
I would be. I'm wondering whether you might be happy to take some medication
What,
to help settle that down.
To settle...
Just to settle down your anxiety.
I don't need, medications to, zonk me out or anything.
No, I'm not saying to zonk you out. I was wondering whether you might be prepared to have some medication just to help settle down your anxiety. Just a small dose at night. Just to get you through this bad patch.
We'll see. I'll have a think about it.
If I organised a few tablets for you, would you just take one at night and see how you go?
Just the one? All right.
Okay. See how you go, and you can always get back to me if there's a problem with it. And I'd really like to see you again, say within a week, to talk about how you're going to get back to work and how we're going to sort all this out. And we'll have the results of our test, our drug test.
And that'll be you?
That'll be me to see you. You come back to see me, yeah.
Right.
So we'll make an appointment on the way out.
All right.
We'll get that test organised.
Yep.
And we'll go from there. And get those tablets organised to you. All right.
Okay.
Thanks for coming in to see me, Pete.
All right.
All right.
Thanks.
We'll see you soon. Okay.
Cool.
Well, that was ingenious. You've managed to get the patient to at least agree to come back and introduce an antipsychotic.
Whether he'll take it or not is another question, of course, but it's a start, and he may well. The key there was to, again, work with what he's worried about, which is his worries and his agitation, not other psychotic phenomena that might be occurring. So again, work with him.
So, and sell the olanzapine
try and
as
sell
an
the
agitation.
olanzapine. That's right, exactly. Yeah, which it's very good at.
Are there any things, looking back on that video now, that you would have done differently?
In general, no. I think that we got to a point where we still had him linked into the service. He still was prepared to come back to check on his test. So we were still connected with his motivation at the end of the interview, and I think that was a really important thing. I think how I asked the questions, I remember I was quite tired when I did that interview, and the questions I asked, I think, could have been a bit different. Like I asked him about strange voices, and maybe I could have, used other words. I think the important thing out of that is that we don't always get it right. It's not always perfect when we look back on it. But the net result is that this guy is actually going to come back. We've joined with him somehow about his motivation for being there, and that's really the key issue, really.
Well, once again, let's have a look at something completely different, a female patient this time, and certainly a reasonably common presentation in general practice.
G'day, Maureen. I'm Jim.
Hi,
Nice
Maureen.
to meet you.
Yeah,
Hi.
you too.
Um,
Look, I'm just in. I've run out of my. I just run out of my scripts, and so I was just coming in. If you could give me another one, and that would be great. It'd be really good.
What prescriptions are you?
Seropax and temazepam. It's just,
Both of those?
Yeah, thank you.
Oh, okay. So how long have you been taking those?
Probably a few months, 6 months.
6
like
months,
that.
or longer than 6 months?
Maybe longer than that. I'm not really sure.
For at least 6 months.
I would say, yeah. Yeah, possibly about a year. Maybe about a year.
Yeah. Okay.
Yeah.
So you've just run out, and because I haven't seen you before, I don't know much about you.
Okay, well,
so-
look, I generally have, it's just kind of problems with sleeping and stuff. I've, found that quite difficult, and so I just have the one, it's just the one at night, and so, but I've just run a little bit short this time around, so, yeah.
Can I come back to that?
Yep.
Just let me ask you, how old are you now?
I'm 40.
40, okay. And where do you live?
I just live in, just in the town actually, just in the main, sort of in the main centre.
In the centre, okay.
Yeah,
all right.
that's right.
Yeah. And who lives with you there then?
I just live on my own.
Do you? Okay.
Yep.
Has that always been the case, or?
My mother lived with me for a little while, and she's had to. I wasn't able to care for her, so now she's in a home, but quite close by, and I visit her most days, and I get her to church most Sundays.
Okay.
Yeah.
So church is important for you?
Oh yeah, yes, yeah, I love it.
So
Yeah,
what else do you
that's
do
right.
with your life? Are you
Oh
employed,
gosh,
or you
that's pretty. I keep myself pretty busy, and so my friend Jan and I we tend to go to church together, and we go to bridge, and I play a lot of tennis as well.
So do you work at all?
Oh, bits and pieces. I've worked part time in the post office for a little while, and that was really nice. It was good. So we, So
I was wondering how you're managing financially. And
oh well, I had a carer's allowance for my mum for a little bit, but no, I sort of keep myself pretty busy and do quite a bit of charity stuff around the place as well. So yeah.
Okay. So come back to the original request here. For what was it?
Seropax and
and
temazepam.
And you've been taking both of those for at least a year.
Yep, and it's been fine. It's been good.
And you've just run out?
That's it.
Right.
Yeah.
When did you last get a script?
Oh, probably about 10 days ago. 10, 14.
So
14 days
how
or
much
something.
are you using them?
Well, I think only the...
I mean, script is... What, how long does a script last normally?
not really sure, to be honest. I think, I mean, maybe closer to 20 days or something. I mean, I don't know. I can't remember how many's in a packet. It's something.
So how many Seropax?
Well, generally speaking, it's only about 2 a day, and just the one at night. I've just
so Seropax two in the day. And one at night?
Yeah, that's right. And generally just the one temazepam at night.
Generally, but sometimes you might use more.
Well, just occasionally. I just have problems with sleeping, and I live quite close to the hotel in the town, and it can just be quite noisy sometimes. And I've just been finding that just a bit. I've just found it harder to get to sleep lately. So sometimes I might have 1.5, or occasionally 2, but only.
So you might get these from several different doctors.
Usually, this is my family doctor who I usually see, but no, every now and then I see somebody else.
Okay. I'm kind of interested to know how you got started on taking these. Did you start both at the same time, or did you just start one?
No, I think I started taking the temazepam first, and that was when my mother was still living with me, and the days it was quite stressful, and I was just finding at night that I was finding it really hard to switch off. My mind was just going round and round and round.
Are you a worrier normally?
Oh, I like things to.
You're somebody who normally lies awake at night.
Well, not lately. No, unless it's been very noisy or something. I've always been quite a light sleeper.
Right.
But no, I don't think I'm an overly worried person. I think I just like things the way. I mean, I like things the way I like them. But I worried quite a bit about my mum. But she was elderly, and she is elderly, and I was quite worried about her. About her mind, and I'd go out to do bits and pieces of work, and I wasn't always sure about what she was doing.
So it was a stressful time for you?
It was a stressful time. I did find out
and that's
she didn't
how
want
you
to go
got
to a
into
home.
the stuff? All right.
Well, that was right.
When did the Seropax start?
Probably not long after Mum left. I would say.
Why did you introduce that? What was?
Oh well, I think it was just just during the day I was just finding it hard to. Just to get through things, I suppose, and just for a little bit. I think Mum had to go into the home, but I found once she left, it was just not a routine I was used to, and So I sort of tried to keep busy doing different things, and you know, and I've got a pretty full and active life, and I just wasn't feeling as on top of things,
Sure.
and this has just really helped. You know,
How does it help you? Tell me in what way does it help you?
Well, I just, I suppose, just more. I guess just a little bit more get up and go, and you know, I've been feeling, you know, just ticking the boxes.
It helps you function?
I think so.
Right.
Yeah.
What happens if you can't get hold of either Seropax or temozolone?
I don't know. I mean, I haven't really had too many problems with.
You always managed to get hold of some, but
Well,
has there been a time when you actually haven't been able to get hold of it?
Probably only about once or twice or something, and it's. Look, I don't think it's a problem or anything. I mean, I think I'm fine, but I just, you know, I just feel as though at the moment things are just, you know, it's just nice to have that sort of lid on.
Yeah. Just wondering what else you actually used. You said you live close to the pub. Do you go to the pub often?
Oh, no, I don't tend to.
Do you drink alcohol at home?
Oh, you know, little bits and pieces. I mean, Mum and I used to have a little.
When was your last drink? When did you last have a drink?
Well, probably last night.
Would you drink every day?
I suppose possibly, but you know.
Yeah, I've noticed today you're struggling to kind of. You seem to be struggling at times to find an answer. Is that?
Just tired.
You're finding it.
I'm
You're
just
finding
tired.
it. Yeah, you must be really tired. Yeah.
You know, so just.
You're still so despite taking these, you're still having trouble sleeping, or?
Well, I think it helps if I have it. You know, it definitely helps, and yeah.
I suspect that you know that there's a difficulty here with overusing these medications that you're on, and possibly you know using alcohol to reduce your worries. I mean, it's a very common problem.
You know, I sort of feel as though the things that I'm taking at the moment are, you know, it's not out of hand, and they certainly, you know, just.
Well, I'm worrying that from my perspective that there may be some better stuff that we can help you with.
What sort of?
Because I mean, it sounds. I mean, you know, we maybe have to see you again to discuss this in the near future. Would you be able to come back and see me, and we can discuss where we go with this? Because I'm very worried about the fact that you're taking two benzos. You've heard the word benzo, yeah?
Yes, I've heard that before.
And that worries me immediately. I think that's probably not useful.
Sure. I mean,
and it sounds like you're actually using a lot, and it sounds like you're using alcohol as well to kind of settle things down for you in terms of your anxiety.
Well, Jim, I think we've all seen that patient. How were you able to get a handle on that? She
was fairly easy to join with, actually. So I felt like she was there for a reason, and I could understand that, why she was there. Mm-hmm. And of course, her immediate motivation was to get some more tablets. So you kind of work with that. But then being very specific and you know have a high degree of suspicion that this woman might be overusing, and partly because of her presentation. Immediately, I get the sense that she's not quite with it. You know, she's seems a bit dulled down, even though she's kind of talking rapidly.
Would there be a very typical patient that you might suspect is going to be at very high risk of overusing?
The anxious ones, the ones who have underlying, you know, anxiety in their personality structure, and in Maureen's case, she's on her own. Her mother has just been, I think she said, you know, her mother's just been put into care. So there, you know, other issues for her there perhaps that she hasn't really had a chance to talk about or discuss. So she's likely to be minimising some of those issues and you know, masking them with benzodiazepines and alcohol.
Mm-hmm. Yeah, especially people we've never seen before. I think you know she falls into that category of someone that you just don't know, and of course some of these people just keep going around to people that don't know them very well and getting prescriptions. The other clue is that she's on 2 benzos, which already starts raising questions for me.
Well, she sounded like she had 2 problems, alcohol and a benzo dependence. Which one would you tackle first?
We probably have to do both, really. I think it's hard to tackle one at a time. And, you know, when she comes back and getting a more detailed history, etc. as well. So and a lot will depend on, you know, what a blood work turns up, etc., and as to which one might, you know, you might want to prioritise. But I guess it's the it is difficult to kind of separate them out. I think. I think the reality is, you know, you end up doing both.
Well, it could be quite complex because ideally, I want to get this woman onto an SSRI.
Yep.
And that might take some time. You know, it takes 6, 8, sometimes 12 weeks before you get an adequate dose that's going to take care of anxiety. During that time, she might be coming off her alcohol, and that itself is going to, you know, anxiety is going to emerge as that's happening. Yeah. Even if she doesn't get formal withdrawal symptoms, you know, alcohol's been dampening down her anxiety. So we're going to need a benzo in there somewhere. So I would use diazepam, and I'd give a strict dose, say something like, you know, 5 milligrams twice a day, to cover that difficult time where someone's coming off their short-acting benzos, and they're coming off alcohol, and they're getting onto an SSRI, which itself might cause agitation initially. Yeah. So, you know, but I would definitely use diazepam of all of those.
And you're looking at sort of a 12 to 20 week time period, aren't you?
You're looking at quite a long time frame. Yes, this is a long-term project.
Yeah. And it's important to warn the patient as well about, you know, how long it'll take, and the fact that she may well feel worse before she starts to feel better, and that's normal, and just hang in with her, and we're going to support her as much as we can. Give us a call, etc., etc.
Just as an incidental to this, a lot of our elderly have been taking a temazepam every night for the last 25 years. Every now and then an article will come up and say, get them off it. Is that something that you would consider in this same kind of dependency scenario?
Not really. But
no. The short answer is no.
I don't think it's particularly practical to get them off it. But,
it just depends on whether it is actually causing a problem. I mean, you know, it depends if they're falling, if they're, you know, all of those things obviously need to be taken into consideration. But as a, you know, an isolated kind of thing, no, it has to be taken into context with, as you say, you know, if this person's been on it for 20 years and been managing okay, well, you need to weigh that up.
Escalating their dose.
Yes, that's right, yeah.
I think it's important also to say that, you know, sometimes there is a patient that needs to be on long-term benzodiazepines.
That's true.
Yeah.
Because nothing else really helps them. I think the problem occurs when there is an alternative treatment that's never been tried. Yeah. That's a lot safer, and that's what I would be concerned about, and that's this case really. She's never been on adequate dose of an SSRI for long enough.
And I guess finally with someone like Maureen, you know, she may not have also thought about, or no one's discussed with her, psychological therapies to help deal with her anxiety. Yeah. And so once she's off, you know, her benzodiazepines and alcohol, that would be another very useful, you know, treatment as well to introduce.
Which is why you get her to come back and you know, because all those things need to be discussed, and you just can't do that in one session.
It's all very long term.
That's right.
Let's have a little look at the management contract that you set up with Maureen, and how this is going to progress over the next few consultations.
So can we make another appointment?
Yeah, okay, all right.
Say within a week? A week or two, maybe, you know.
Okay.
But the important thing here is as well, and that you actually follow up with one doctor, that you don't go seeing a lot of different doctors.
Okay. All right.
There are ways of checking through the pharmacies as well. I don't want to have to do that, but as to how much people are taking. I'd rather that we had a trusting relationship and we can kind of sort this out.
Okay. That's fine. I can make another appointment for in about 7 or 8 days or something.
Yeah, sure. All right. And let's make that a definite. Let's make it a long appointment that you keep. And you can have a serious think about, you know, about alcohol. And in the meantime, I will write your script. I'll leave it out the front for you for what you're on at the moment.
Okay.
With a view to reducing that, I'm going to be very strict, right, by saying, okay, we'll keep you on what you're saying you're on at the moment, which is Seropax, and the temazepam, the doses we talked about. But we'll be aiming to reduce those.
Okay.
Yeah. We can't go on doing that.
Okay.
Is that all right?
All right.
So,
yeah. Yeah.
Just before we stop, there are no risk issues here in terms of you harming yourself or anything like that?
Oh, no. No, none at all.
Okay. Just thought I'd ask.
No, that's no. Look, I completely understand. No, look, no, that's the.
Right. You've never done that in the past?
No, definitely not.
Okay.
Definitely not. No, yeah.
Now, I noticed that right at the end you just picked up and said and checked with her that she wasn't suicidal, and she certainly didn't sound suicidal. How important would it be to actually check in those words in a patient that just presents like this?
Yeah, that's a good question. I think what happened in that consult was that I was kind of focusing very much on her alcohol and medication misuse, if you like. And in my mental state review, which was kind of subtle, it wasn't like a formal thing, I didn't actually specifically ask about her risk of self-harm or of suicide. My gut feeling was that she had a future and she wasn't at high risk. I think it's very important to actually ask the question, which I did right at the end. Yeah. And the other thing is that it's no shame if you realise that you've forgotten that, and to actually ask it. Okay, you've forgotten. Sometimes even the patient's gone home and you feel you didn't ask, so you might just get someone to check on that, or when they come back. You
mentioned the checking up through the pharmacy, and it didn't seem terribly threatening, although I'm sure the patient might have been a little taken aback by that. How useful are the pharmacy checking and the doctor shopping hotlines?
I think they can be extremely useful. Sometimes the only way you actually find out what someone's taking. I've had cases where people are taking phenomenal amounts of stuff, and it is a very useful kind of backup. But it's also useful to use as a boundary setting device for patients. So that, she seems a fairly kind of compliant patient, really. She's somebody that I believe would probably respond to some fairly firm but kind boundaries.
And framing in terms of concerns
for
her health,
that's right. Yeah.
As opposed to this as a punitive measure, would be important too.
Any final thoughts on consultation tips when you're dealing with a psychiatric patient?
As in any consultation, I think with any patient, I think the time, if you can, that's required to take to establish a relationship, to establish the rapport is vital, particularly with our psychiatric patients. And recognising that and maybe needing to take longer for those patients is important.
I think adding to what we said earlier, a high index of suspicion as well for depression, anxiety, especially. They're very common, but they're often hidden.
And thank you to Jim Goodburn, Eileen Tay and Olga Ward. If you're interested in mental health, our February 2011 program will also involve Jim and Eileen, and they'll be discussing some specific mental health management issues. Now, don't forget, this triennium for CPD points is coming to a close. To make sure you receive your points for the Rural Doctors broadcast, please complete and return all evaluation forms no later than the 19th of November. Now, remember too that this program or any of our programs going back to 2008 are available to access on our website at ruralhealthwest.com.au. Full sets of 2009 and 2010 DVDs are also currently available for just $80 for a set of 10 programs. To order, simply call Rural Health West reception on 08 6389 4500. So from all the team here at Rural Doctors, we wish you a safe Christmas and a Happy New Year. I'm Jerry Gannon. Thanks for joining us.